Hello, everyone. Welcome to our translational webinar series. This series is a webinar as a joint effort of the International Cholangiocarcinoma Research Network, ICRN, the European Network for the Study of Cholangiocarcinoma, ENSCA, and the Precision-BTC-Network, which is a cost action. My name is Stephanie Roessler, and I'm a basic scientist and professor at Heidelberg University Hospital. And I'm co-chairing this session together with Pedro Rodrigues, and he's a group leader and principal investigator at the Health Research Institute in San Sebastian, Spain. And we are very happy to welcome everyone and very excited about today's presentations. And we have two very excellent speakers today. But before, I just briefly want to let everyone know that we have for all of the live attendees, the possibility to receive attendance certificates. And then the speakers, they have all agreed to record this webinar. So this webinar will be recorded and then uploaded to the CCF YouTube channel for future viewing and also for informational purposes. So by participating here, you also agree that in case you ask questions, these will be also used and posted online. And we would like to invite everyone to ask questions along the way. So please stay unmuted during the presentations. And if you have any questions, then you can raise your hand and unmute and ask the questions. And you can also use the Q&A section to write your questions. So without any further delay, I would like to very warmly welcome our two speakers who are very excited. The first speaker today will be Dr. Mitesh Borad, and he's a leading expert in oncology and precision medicine. And Dr. Borad is an associate professor of medicine at Mayo Clinic, where he serves as the director of liver and biliary cancer research program, and he leads the Cancer Cell Gene and Virus Therapy Lab. His groundbreaking work in targeted therapies, particularly in cholangiocarcinoma, has opened new doors in personalized medicine. And he's also involved in clinical trials and shaping the future of oncology. So the second talk will also focus on oncolytic viruses and also combining CAR T-cell therapy. And this talk will be given by Dr. Yuman Fong. He is an internationally renowned surgeon, scientist, and innovator in this field. And he serves as the chair of the Department of Surgery at City of Hope Medical Center. And Dr. Fong is a pioneer in oncolytic virus therapy, exploring the use of genetically modified viruses to treat cancer, and has led clinical trials. So we are very happy to have these very excellent talks. And I would like to start with the first talk of Mitesh Borad. Can you share your slides yourself?
Yeah.
Very good. Yes.
Can you guys see the slides?
Nice.
Yes, very nicely.
Okay, wonderful. Well, good morning, good evening, depending on the time zone that people may be in. It's an absolute honor and a pleasure to be here with Dr. Fong today to present this webinar. And I thought what we would do is break it down into two modules here. And the first one, which I'll present, will talk about oncolytics in general, and I'll show characteristics of various vectors and vesiculoviruses as an example of a platform, and then I'll pass the baton on to Dr. Fong. Okay, so we've coexisted with viruses a long time, and we've known of them since the late 1800s, when scientist Martinus Weijernich discovered a plant virus called tobacco mosaic virus. We have known of the influence of viruses in cancer also since the late 1800s, where spontaneous regressions of cancer such as leukemia were noted in patients who had gotten the flu. since the late 1940s through 1970s, the application of viruses to cancer had predominantly used wild-type viruses. However, as you can see, these are fairly pathogenic viruses, and while they did have impact in terms of anti-tumor activity, they also caused disease, and in some cases, pretty morbid and occasionally lethal diseases. And as such, the use of serious pathogenic wild-type viruses was largely abandoned until advances in molecular biology could make these vectors more selective and attenuated. Okay, so if you look at platforms, you can broadly divide them by whether these viruses are DNA viruses or RNA viruses. To the left, you can see some examples of DNA viruses. Advantages of DNA viruses can be that you can control them through their promoter for selectivity. Some disadvantages may be that some of these viruses rely on the cell cycle for their proliferation, and as such are felt to be slower than RNA viruses, which may replicate much quicker once they're in the cytoplasm. To the right are RNA viruses such as polio, vesicular stomatitis virus, which I'll show in a little bit, and measles virus, which has also been in the clinic for cancer. Herpes simplex virus, which is a DNA virus, constitutes one of the few FDA-approved therapies till date, and this, as we know, is TVEC in melanoma. Okay, so what are some of the desired attributes? You want these things to be specific to the tumor, especially if they're pathogenic. And then you may want them to replicate very rapidly if you're looking for lysis, and somewhat less rapidly if you're looking for an immunomodulatory effect. Of course, if you're giving them systemically, you want vectors that have low pre-existing immunity, because otherwise they'll get neutralized. You want to be able to manipulate the genome so that you can go from wild-type viruses to newer vectors. And in the initial days, you want to see where these vectors go. So you want to be able to put genes that can allow you to track the vectors. Okay, so I'll talk a little bit about VSV. As you can see, it's a bullet-shaped virion. The size is 200 by 75 nanometers. So you can very much consider this a nanotherapy. You can see it's a simple genome. It's a negative strand RNA virus with the nucleic acid encapsulated in a lipid bilayer, and you have a glycoprotein on the outside, which allows for viral entry. It has 5 genes, as you can see, and the genome is only about 11,000 base pairs. So normally it does not affect humans. It affects cattle, horses, pigs. These are the natural host, and it causes mouth sores in these animals, and sometimes it can be fatal if the animals can't eat for a long time. So this is a small genome. You can manipulate it easily. It can get into most mammalian cells. One particle can produce 10,000 to 100,000 particles in just a day. There's very little pre-existing immunity, and it takes advantage of a mechanism where cancer cells in many tumors have defective type 1 interferon pathways, and these are intact in normal cells, so you have tumor selectivity. It takes a big team to take these vectors from discovery all the way to the clinic. You need experts in GMP production, toxicology, of course, preclinical studies and clinical trials. You can see how long it can take from the first discovery to how long you might even dose. So you can see it took 12 years from the first description, the first patient dosed. And of course, we've known about these viruses since the 1800s. As I described before, tumor cells have defective type 1 interferon pathways, normal cells don't, and that provides the selectivity. And then, of course, if you have a vector that has interferon beta in it, you can further enhance the selectivity where the vector makes its own neutralizing mechanism. Okay, and we see that there's this selectivity in tumor cells versus normal cells in vitro studies. And in a first-in-human study that was conducted in 12 patients, in refractory patients with hepatobiliary cancers, there were generally low-grade events, such as effects that you would see with viral illness, such as injection site reaction, flu-like symptoms, myalgias, and headaches. And there was some preliminary anti-tumor activity noted with necrosis in injected lesions, as shown here. Patients who had alpha fetoprotein that you could monitor, you could say that it increases here in this patient for about 3 months, and then there's a sustained decrease for almost a year. And then you could also see effect in lesions that were not injected. So the lesion I show here, which has shrunk, was a lesion that was not injected. So this is what we would consider an abscopal effect. However, as we tally up the results, it had modest single agent activity. So only one partial response by RECIST criteria, some stable disease, and most patients didn't benefit. As we dived further, what we found in laboratory studies was that the attenuated vector really posed a disadvantage in the end, because not all tumor cells are completely defective in interferon. They might just be defective in interferon production. So this vector, which had interferon encoded in it, neutralized itself. So shown on the bottom is a tumor cell that is no longer impacted, and on the top is a tumor cell that remains impacted. So it turns out that this is about 15% of tumors, which, as you can see on the left, most tumors are killed. And once you have interferon in the in the vector, you have a big shift where only 10 to 15% of the tumors are killed. And that's around the amount of activity we noted. So you can classify tumors based on whether their induction and signaling pathways are intact or deficient. And it turns out that there may be 3 or so phenotypes of the virus. And you can see that these tumors would be resistant and comprise about 85% of human tumors for most solid tumors. So we could do better selection, of course, but you'll only be able to impact about 15% of patients. So we also noted that these viruses have neurotoxicity. That's why we had to attenuate them. So could you go to other vectors? We developed another vector called Moritone virus, which is in the same genre here. And it also has a bullet-shaped structure, about 11,000 base pair genome. And we also found that this was able to replicate at a very high rate. It was not cross-neutralized with VSV and was also sensitive to type 1 interferon. So we could take this virus and not have to attenuate it and go into a variety of cell lines, including many biliary tract cancer cell lines shown here. And we saw that the receptor is not the same as VSV because it doesn't get neutralized when you block LDLR receptors or knock it out. And in safety studies, we saw that it did not have much effect on weight and other factors, and that it had very little neurotoxicity. So now you can take this vector and inject it unattenuated in early studies. It had in xenograft models, you could see this biliary tract cancer model. It did not have much effect. It had significant effect in this hepatocellular cancer model. However, in an immune competent model, it was quite effective with reduction in tumor shown here to the left. And we saw that this mechanism was through an immunomodulatory mechanism, primarily comprising cytotoxic T cells and a shift in the macrophage phenotype. So we know single agents are not going to be enough, so likely we will have to use immune checkpoint inhibitors. And future efforts will involve use of other platforms, combining these treatments with cell therapies, as you'll hear in a little bit, pivoting these towards gene therapy methods, gene editing methods, and seeing if you can identify which patients are going to benefit the most or not. And eventually, maybe you won't have to use viruses themselves, where you can just infect patients with the RNA of viruses and let your body produce the virus. So a lot of folks have contributed to this. Special thanks to patients and their families who participated in the clinical trials, all my collaborators, and all the funding sources that made this possible. So I'll stop there and I'll pass it on to Dr. Fong.
Quick question. I wonder if I can jump in, Mitesh, with a very quick question.
Yeah, go ahead.
Thank you, Mick. So thanks for that excellent presentation. You mentioned that neurotoxicity was dose limiting. Is this something that's seen across lots of viral vectors, or was that very specific to that one?
So this virus is in the same group as rabies virus. It's a rhabdoviridae. So there was already concern about it having neurotoxicity. We didn't note it in the trial other than the headaches, but the vector we were using was an attenuated one because it already had interferon in it. So we were never allowed to test the wild type VSV in patients because of the theoretical concern. So the FDA and other regulatory agencies will not let anyone take VSV directly into the clinic.
Thank you.
And sorry, Mitesh, if I'm also allowed, first of all, thank you very much. It was a very, very nice presentation. And I was wondering, because you talked about the seroprevalence, for example, of some virus, and the immunity against the virus might be important. So do you think that, for example, during treatment, there might be an option that the patient acquire resistance to the virus, so the immune system might recognize the virus and erase them from the system before it does the affect the tumor with the prolonged exposures?
Yeah, so this comes down to the method of delivery of vectors. So if you give these vectors intratumorally, you can avoid some of
that.
things.
Yeah.
But for patients who have metastatic cancers that are widely disseminated, that approach may not be sufficient, although you can rely a little bit on the abscopal effect. So if you want to give the vector systemically, most viruses will already have significant amounts of neutralizing antibodies about 2 weeks after their first administration, if there was even no pre-existing immunity to begin with.
Okay, thank you. So I think we can proceed to Professor Yuman's Fong presentation, and then we continue the discussion.
Yeah. Mitesh, thank you very much for setting the stage. And I've been working in viral vectors for a long time. And in fact, I took one of my sabbaticals there with Stephen Russell at the Mayo Clinic. And so I just want to go talk through what we're working on and how the field is moving. And this is where I work. This is the City of Hope Cancer Center in the desert on the edge of Los Angeles. And I've been here for the last 10 years after 30 years at Sloan Kettering. And what we're working on are really combined viral and T-cell therapies for cancer. This is how it works. Virus infects cancer cells, duplicates in cancer cells, and kills cancer cells. This is a plate of very resistant mesothelioma cells. And I could show a slide, a video of other cancers, but mesotheliomas are completely resistant to chemotherapy and radiation in general. Almost everybody who gets mesothelioma dies. And here's a plate full of tumor cells that we've thrown one virus per 100 tumor cells in there, and within about 13 hours, they're all infected. They then burst. You can see these getting bigger and bigger, full of viruses, and burst. And then within about 24 hours, these plates are clear. And that's what we would like to go do. So the idea of making a virus target only cancer and target cancer in a huge way and leave all the normal cells alone is not out of the realms of believable, because that's what nature viruses do. Hepatitis virus only infects liver cells. no matter where it enters the body, okay? And meningitis virus infects only brain and neural cells, no matter where it enters the body, as long as it finds its some reason to replicate and live in certain cells, we may be able to restrict killing of cells only to cancer. So if you think about how radiation chemotherapy kills tumors, okay, and as we apply chemotherapy and radiation to tumors, in general, what happens is that apoptosis happens. We activate many apoptotic pathways, including caspase-3. Then the cells actually do a killing of itself through apoptotic pathways. And it turns out when chemotherapy and when cancer cells become resistant to chemotherapy and radiation, these cells are very anti-apoptotic. Well, it turns out apoptosis is actually a defense mechanism of cells against viruses. That's how, if you get a bad infection, what cells try to do is that it tries to go into apoptosis. So anti-apoptotic cells are highly facilitating for replication of viruses. That's why, again, there is a belief amongst those of us who design viruses that if we find cancer cells that are actually very resistant to chemotherapy or radiation, they should be the perfect places for replication of virus. It's also that radiation chemotherapy have trouble killing stem-like cancer cells, like these clusters of cancer stem cells, and viruses don't care. Okay, this is a stem cluster. All the green cells are actually virally infected, and because in the petri dish, we tend to label a lot of our viruses with fluorescent green to show infection. Radiation and chemo-resistant cells are also activated in DNA repair mechanisms, which are perfect for viruses. They are often hypoxic. Viruses don't really care. They are high in intracellular nucleotide pools, which are also very, very favorable for viral replication. And that's why in most viral trials, we don't care about having first line, okay? And we actually prefer to have tumors that have been selected to be kind of resistant to radiation chemotherapy. And those are the cholangiocarcinomas that we're talking about. We've also come to realize that it is not just direct lysis that we rely on the virus to do. It's also immunoactivation. Again, viruses are really good at turning tumors hot, meaning that it's really good at turning on checkpoints. So that checkpoint inhibitors may be useful. It's very good at attracting T cells to the local site. In fact, Pedro, what you were asking about in terms of immune reaction to the virus. There are some viruses that the immune reaction is so good that we can never give a second or third dose. Those are the adenoviruses, okay? Those are the common cold viruses. That's why it's very hard for somebody to catch a cold a second time or third time in the same season. And whereas there are many viruses where we can actually have it be advantageous. So that's why herpes viruses, that's the cold sore viruses. Why is it that we people who get cold sores get it reactivated all the time? Because these viruses actually live in some of our nerves in a latent form, and even with preformed antibodies, they come back to life when we're stressed. And in fact, TVEC, which is based on the cold sore virus, they actually immunize the patients with a small dose before they actually give a full dose as treatment, because they believe that by that vaccination, you could actually turn and rev up the immune system in terms of reaction to the tumor as a bystander effect to the reaction to the virus. So again, many things we have learned in the last 30 years, which is really the life cycle of our knowing how to genetically engineer viruses. It's only been since the 1980s. Natural viruses, Mitesh already talked about a lot of them that have gone to human trials. In fact, West Nile virus was found to be one of the very best natural viruses for killing cancer, but all of them are kind of poisonous for the human, and therefore that's why they're not really used in wild type form anymore. But engineered viruses, there are many of them that have been put to trials. And for last generation virus, here's a study we did way back in 2006 using herpes viruses for killing of many different types of cholangiocarcinoma. It replicates within the tumor cells, and if you wait long enough, almost every cholangiocarcinoma cell line will succumb to the use of oncolytics. This one in particular is herpes simplex. But I'm going to talk to you about the fourth generation viruses now. The third generation was really the last generation. These are all the ones that went into trials back in the 1990s and early 2000s, and there were a huge number of trials, and only one came out of these trials and as a medical product, and that was T-VEC. And the reason for that was because we were so worried about hurting human beings with viruses that we made the viruses much too attenuated. Most of them barely hurt cells at all, okay? And the path was too slow. The FDA made us do single dose trials, then multi-dose trials, then combination trials. By the time we actually went through these trials and came back to the FDA for further approval, and then for further approval, it was a decade down the line. IP was running out. They weren't very good viruses to start with. And so, again, it was because they were attenuated, they were also too expensive to deliver. The doses had to be so huge that you couldn't really make them for reasonable amounts of money, and it was poor efficacy. And that's why, again, that entire generation of viruses, only T-VEC became the real therapy. But we learned a lot, okay? We learned that it can infect and kill stem cells. And then when you look at nerves, right, because that's what liver cancers and pancreatic cancers and cholangiocarcinomas do. They actually do perineural invasion. Tumor cells actually crawl up these nerves. You can actually watch tumor cells move along the nerves, which are centimeters in length, and travel to distant places. Well, viruses sort of crawl up there with it, and there have been many papers written now where we can show even with neural dysfunction, you can actually reverse it by sending viruses up nerves to kill cancers. And it's also very clear that viruses can track up lymphatics, and you could actually go into the lymph node that has cancer, and viruses will track right up all the lymphatics and go do the work. Okay, and so again, we learned a lot about what it can and cannot do. So we as a group decided, there were 5 or 6 groups that rebooted about 2015 when T-VEC was approved. It was very clear that the last generation was not very good. So there were a number of different strategies by which the viruses, new generations, the 4th generations, were remade. And what we did was something that was different than everybody else. We basically took a whole bunch of vaccine strains of viruses and combined their pieces. We actually took them apart, put them back together, and created hundreds and hundreds of new viruses that never existed on Earth. And then we put them through high throughput screening. Okay, basically we said, what would nature do if it was trying to design a virus just for killing of cancer and to leave all mammalian healthy cells alone? And what drug companies would do, right, would be to go through, put it through high throughput screening to see which compound would be best. And this time, instead of asking, will our virus kill brain cancer, or will it kill mesothelioma, or will it kill melanoma, we said, let's go and try to kill everything. So we took the NCI-60, which is the panel of 60 cell lines that the NCI uses for screening of any drug that is put in front of them. We added another 40 or so of cell lines that we thought could have immunologic signatures for targeting. And so about 100 cell lines, and we said we only cared about the viruses, the new viruses we created that killed all of them. And we found 5 or 6 of them that were really, really good. And in the 33rd clone of the viruses that we created, it's called CF33. It's called 33 because it's the 33rd clone. And if you look, every different color is a piece of DNA from a different virus, okay? This is a life form that never existed on Earth. We put all of these through high throughput screening. We then injected them in animals to prove that they were safe. This particular virus, we had to go to enormous doses to create any toxicity in animals. Then we said, let's go test, okay? So this is a generation 4 pox virus. Contains pieces from vaccinia, rabbit pox, cowpox, raccoon pox. and has high anti-cancer potency, meaning that in animals, we were able to cure many, many cancers at 10 to the third. 10 to the third, okay? And that's about 3 to 6 logs lower than other viruses in human testing in the last generation. The preclinical data also demonstrated enormous safety, and now this virus, the CF33, went into clinical trials in 6 centers in the US and in 3 centers in Australia, okay? And it's currently in 9 centers. And when we went to human clinical trials, because we didn't really find a cancer type that we couldn't kill, we did not say what cancer we were going into. It actually went into any cancer if they've already had first and second line therapies. Cholangiocarcinoma, we knew was a promising thing, and that's because when you gave even 0.01 MOI, that's 1 virus per 100 tumor cells, if you waited long enough, 120 hours, all of the different cell lines that we treated, the cells were gone. So this was our mass study. Basically, any cancer, there was an IT, intratumoral cohort. There was an IV, intravenous cohort. So this was licensed out to a company, and I did not do these trials. And when they told me they were going to go do multiple dose IT and IV, at first I go, well, the FDA probably will make you come back and say, and do them separate. Turned out they didn't. And then when they said they were going to go immediately, if they were safe in IT and IV, roll into a combination with Pembro, I told them that I don't think the FDA will ever let them do that, okay? And they did, okay? And so this became a trial that moved along very, very fast. And during this trial, when we got into reasonable doses, which is up here at 10 to the 7th, now I want to point out 10 to the 7th is still a teeny tiny dose of virus, okay? And they started noticing responses. And of the 2 patients that were treated with cholangiocarcinoma, only 2 went into this phase 1 trial. Both of them had remarkable responses. Here's a patient with peritoneal disease. And I apologize for my room because there's a light sensor on the side that turns off the lights when it doesn't think I'm here. And whoever was the architect put it around the corner from where I sit, okay? I apologize for that. So one of the patients at 10 to the 7th dose IT of one of the deposits in the peritoneum had a complete response in that all of the spots disappeared, or they grew first in a pseudo progression, then they responded. And this person's been off therapy now for over a year, off any therapy for over a year. And then a second patient who had previously progressed on checkpoint blockade therapy achieved stable disease now over 8 months, and both of them are still doing pretty well. And because when I send in my viruses, I listened to Stephen Russell, and I said, I will put HNIS on my viruses. HNIS is human sodium iodine symporter, which is the gene in our thyroid cells that allow our thyroid cells to concentrate iodine in order to make thyroid hormone. All of my viruses pretty much carry this gene. Therefore, I can just give either iodine, naked iodine 124 and do PET scanning to see where the virus is gone, or I can do technetium scanning and see where it's gone. And so in this trial, we actually did SPECT scanning using technetium, and in these areas of injected tumor, there was enormous replication of virus. Okay, it was so we actually have biologic correlate of the replication of virus in these sites of tumor. So quite interesting, exciting, but only 2 patients so far. So that's why this trial has now been rolled into a phase 2 of only cholangiocarcinoma patients, and that's now started. I've not been told what the results are yet, but it only just started a few months ago. And a number of patients have been entered, and I think they're rolling along very, very fast. Again, not done by me, and not done by and done in a multi-center fashion. So one of the other things that we have learned from all of this, because again, we've been biopsying all these tumors and looking at the microenvironment. And if you think about all the things in a tumor microenvironment that are anti-tumor, those are the N1 neutrophils, the M1 macrophages, all the NK cells and the effector cells that come, and the pro-tumor microenvironment, which are all the suppressor cells, the Tregs, the N2 neutrophils, and M2 macrophages. What we have come to realize in many oncolytic viral studies, but certainly in our study, we have now proven it. Again, it enhances checkpoint expression, and so very clear that we can now turn up PD-1, PD-L1. It directly kills M2 macrophages and recruits CD8s and CD4s and NK cells to the sites of tumor, and we actually have that as evidence. And so we're quite excited about our virus, and we're not even at the doses I think will produce the best results yet, okay? And so that's all moving along. But meanwhile, in the lab, as you know, chimeric antigen receptor T cells are an enormously promising therapy that in liquid tumors have achieved their promise. And how this works is that, again, we take a cancer patient, we actually do pheresis, leukapheresis, we enrich the T cells, we reprogram the T cells using usually a lentivirus that goes in and changes the cell surface receptors to recognize something, a protein on a cancer cell, and then we expand the CAR T cells, these chimeric antigen receptor T cells, and we reinfuse it for killing of cancer. And we all have known T lymphocytes can kill cancer if it recognizes it as foreign, and T cells can be genetically engineered to recognize cancers. And the CAR T cells directed to CD19, which is a cell surface marker on B cells, are the most successful so far, okay? Again, B cells are those cells that make antibodies. And when somebody gets B cell lymphomas or B cell leukemias, all of the tumor cells express CD19. It's actually very homogeneous, and it's a really good target. And it turns out when you make CAR T cells directed against CD19 and send it in, even if somebody's failed chemotherapy, failed bone marrow transplant, you can actually still send about 60% of the patients into remission by using their own engineered CAR T cells. And that's why August 2017, Novartis product was recommended for FDA approval. Now there are 4 products that are approved in the United States as a CAR T cell directly against CD19 for B cell lymphomas and leukemias. In solid tumors, however, it's been really hard to do the same, okay? And that's because many cancer antigens are expressed in normal tissue. So if you think about HER2, you would think, given how good HER2 is as a target for breast cancer that are HER2 positive, that we would have a CAR T cell that's made against it already that is in use for breast cancer. It turns out the heart has a huge amount of HER2 expression. So the first 10 patients that actually got treated with HER2 CAR T cells at NIH, I think 8 of them died of heart failure, okay? And it was a very, very sad day in an experimental therapeutics because, again, it was just so toxic. Many specific cancer proteins are intracellular. So you would think that since 80% of the tumor cells and liver cancer express AFP, we would be able to target it. Turns out most of it's intracellular. So people have been trying to target parts of the AFP molecule that's been brought to the cell surface as an antigen, but it's been really, really hard. And then lastly, in solid tumors, unlike in liquid tumors where CD19 was expressed in every cancer cell, expression of tumor antigen is very heterogeneous. And what I mean by that is that you think about HER2 expression. This is 0, this is 1+, this is 2+, this is 3+. But in reality, when you look at a whole tumor, breast tumor, this is what you see. You see areas of 3+ and areas of 1+ or 0 in the same tumor. Therefore, it becomes really, really hard to make a CAR T cell against HER2, even if it didn't hit the heart really hard. Then when you look at all the tumor antigens that we've been trying to get at, you look at all the normal tissues that could express them. Here it is, okay? That's why PSMA, there are many different normal tissues that express it. EpCAM, okay? Look at all the normal tissues that express it. That's why we've not been able to make a CAR T cell against a solid tumor and make it really good, okay? So those of us who've been sitting around for a while doing this said, wait a minute, if we had a virus that is really good in infecting tumors, and it infects tumors at very small doses and replicates like crazy, what if we asked it to put tumor antigen on the tumors, also tag it? Not only kill it directly, bring immune cells to kill it some more, but now we're going to tag it, like laser tag it for a missile to come and kill it in a huge way, okay? So we said we had a virus that doesn't really infect normal cells, or even in the rare case it does, that doesn't replicate. Now it infects tumor cells. We would like it to kill tumor cells, but also put all these CD19 antigens. So we go, let's go CD19. There are 4 products approved. Can we use this as a universal CAR T cell for all solid tumors, since we also have a virus that could infect any cancer? So that was our strategy, and this is a paper we published in Science Translational Medicine, where if you take a look, okay, this is virus at an MRI of 1, just 1 virus per tumor cell, and you can see full expression of CD19 on this. It turns out to be breast cancer, okay? And but we've done it in pancreatic cancer, prostate cancer, ovarian cancer, pancreas cancer, head and neck cancer, glioma, and now we've done it with cholangiocarcinoma. We can actually go put CD19 on the cell surface. And then if you send in CAR Ts directed against CD19, it really kills it very, very, very well, okay? But the thing that was even more exciting to us and got the cover of Science Translational Medicine is that by sending in our CAR T cell, we actually release virus much faster, because now instead of waiting for the tumor cell to be so chock full of virus that it bursts, by sending in the CAR Ts, actually released it. So if you look at this panel down here, no treatment, then oncolytic virus only. So these are green virus cell, infected virus cells. Then this is with mock, and this is oncolytic virus with CAR T cells. There's a huge amount of release of virus, and then infects even better. So we think that by putting the virus in, not only will we help viral replication and killing of cancer, it will then label up the cancer cells for killing by CAR T, but by doing that, we can also recruit more tumor cells to be infected by spreading virus much faster. So we're now in the midst of working on whether it should be a autologous CAR T or whether it should be an allogeneic CAR T that we use. That's because there are a few products coming to human testing, in human testing, allogeneic from placentas, from cord blood, from iPSC, and most recently from donors, okay? It turns out if you do pheresis from healthy human donors, you could get out huge amounts of healthy T cells for modification, and you suddenly get many, many more doses from each pheresis. And so many of these are being worked on, and we're hoping to bring this strategy to human testing sometime next year in 2025. These are all the CD19 CAR T cells that are approved. And so we could certainly go just do that, okay? And but we're trying to see whether we can actually find an allogeneic CAR T so that it would even be cheaper and be much more useful to everybody. But it turns out CD19 therapies are not just CAR Ts, right? We actually have monoclonal antibodies directed against the CD19, bispecifics, and ADCs, okay? These are antibody drug conjugates, and so these are all possible, and we are already in human testing in any tumor using our CD19 virus plus Blincyto, okay? And so we're hoping that this will extend beyond CAR Ts, which are right now very expensive, to less expensive bispecifics or ADCs. So again, very excited. This is my last slide, and we are in phase 2 ITIB for cholangiocarcinoma. We are also designing a trial for peritoneal cancers, which will include cholangiocarcinoma, since that is one of the ways that patients with cholangiocarcinoma progress and die. And then we're hoping to be moving into ITIV or IP virus plus CAR T or ADC for cholangiocarcinoma, hopefully as soon as early as next year. And again, I'm so honored by being invited to speak and to share the podium with Mitesh today. And that's because, again, what the Cholangiocarcinoma Foundation offers to patients and to researchers is really acceleration of how we go move things, how fast we can move things along to make it real therapy. So again, that partnership that I'm hoping for is really trials accrual to get data to prove it one way or the other to hopefully benefit patients. Thank you.
Thank you very much, Professor Yuman Fong. It was an outstanding presentation. I'd like to remind the audience, if anyone wants to ask any questions to the speakers, you can either turn on your cameras and ask yourselves, or even write in the chat, and we will ask the questions to the speakers. In the meanwhile, while we wait for some questions, I may start. Professor Yuman Fong, I probably missed, but I would like to ask you regarding the CF33 virus. How are these viruses specific to the tumors? Why they did not affect? Do you know why these viruses do not affect the normal cells and are highly specific for the tumor?
I don't know all the answers yet, okay, but in general, viruses infect tumors better for a number of reasons. One is that viruses like non-specifically sticking to the surface of tumor cells because tumor cells have a lot more heparan sulfate on the cell surface. And so in general, if you send viruses in, they tend to stick to tumor cells better in a non-specific way for internalization. This particular virus is a pox virus, so there is no receptor, so I can't point to a receptor as the reason, whereas in herpes virus, there are 4 receptors that allow herpes virus to enter the cells better, but pox viruses don't do that. There's actually a transmembrane transit that is not receptor dependent. It certainly would relate to higher intracellular nucleotide pools and the anti-apoptotic state of many of the cancer cells. But I can't tell you that I actually know completely. My PhD students are working on it. And but you know, last generation, right? We were trying to be so smart. We were trying to go, let's go design it to go do that. And our guesses just weren't good enough. And so this time I said, let's not go do that. Let's go and just help nature to go do this, okay? Because basically what we did was we accelerated evolution for the killing of cancer. That's what we were doing in the laboratory. We were saying, we really don't care how it does it. We just want it to kill cancer best and to be more selective. And so I'm hoping that a few of the theses coming forward from my PhD students will tell how. But I'm just very happy that we have these 5 or 6 viruses that seem to be very, very specific.
Hopefully in the follow-up webinar, we will have some answers. Professor Ronvaya, I think you want to ask something?
Yeah, thank you again, Mitesh and Yuman. Those are fantastic presentations and really give us a good insight into where the field is up to. I have a couple of questions, which may be a little bit naive, so please forgive me. But the first one is, we know that viruses frequently mutate. So how stable are the viruses once they're created or injected? And the second question is there an ability to switch off a virus? Just really thinking about the challenges of that HER2 story that you told us in solid tumors with a cardiac toxicity, is there an off switch that can be implemented?
Yep. So in the last we learned a lot from the last generation in terms of mutation. Okay. In fact, one of the things I say to my students when they go, how do we go design a virus for use in humans? I go, it's got to be pretty stable. So last generation, I worked mostly on herpes viruses, and one of the things we always did every time we thought we had clinical candidate is we passaged it in brains of mice. If you go 10 passages, usually wild-type viruses will be so mutated as it keeps going that by the time the 10th comes and you sequence it, it's very, very different virus. Okay. But the viruses that were chosen to go into clinics in that generation, they were all ones that even at 5th or 10th passage through mouse brains are highly stable. So we have now done the same thing here. We talked a little about neurotoxicity earlier. Many viruses can have major neurotoxicities, and pox viruses certainly can have that. The FDA actually makes us and inject it directly into mouse brains and go and assay for it. But we've also recovered viruses, repassaged them, and the CF33 was chosen partly because it's been enormously stable, okay, and very little drift, even in 5 or 6 or 10 passages. And so we are quite confident we can make identical viruses even in multiple generations. But that's why it's also that we have to make giant seed stocks, okay? In a freezer is actually a huge amount of seed stock. So every time we go make a new batch, it's really more 1 or 2 generations from the original rather than it being many, many generations from the original. So again, that's genetic drift is something that we all worry about.
And the ability to switch them off?
It has not been necessary. There are certain viruses that could go into latency and reactivate. And so that was the big worry about herpes simplex, because since there was 10% of humans, right, that get recurrent cold sores, and we know it's hiding in the trigeminal nerve in our facial, and it's reactivated by stress. So there was a time when we would have to go and put it in in monkeys and then do whole body radiation to look for reactivation. Okay, but it turns out if you turn off certain genes in the viruses, it rarely reactivates. So we learned that, again, that was something that we learned hugely from the 3rd generation. We learned how to make it really, really safe. And so most of the folks working on the 4th generation now have learned from those and have done all those things that does not allow latency and reactivation, as well as huge genetic drift.
Thank you.
Again, the sun finally came up here in California. And that's why even with my lights just switched out, I still have background light. So I apologize for the lights going out.
So probably before running, I would like to also ask one question to both speakers. So as you probably know, the cholangiocarcinoma tumors are highly enriched in stroma. So they have a lot of other cell types, immune cells, fibroblasts, and a lot of collagen and fibers that actually are associated with resistance to therapy, because it somehow makes a barrier for the drugs to interact and affect the tumor cells. So do you think this might also be an issue with the virus? So may the virus be somehow impacted by the stroma component of the tumor, or are the virus also known to impact, for example, cancer-associated fibroblasts? Do you know anything on this?
We do know that something on this, Pedro, because when we first started spinning out our virus and this generation of viruses, I was going to go the usual, okay? I was going to go melanoma, all the other ones that are much easier, okay? And that's why it was quite a pleasant surprise in this trial when the 2 patients that were treated for cholangio both seemed to have biologic response, okay? And then we went back to to push it on cholangio as well as pancreatic cancer, which is also highly stromal. And we are quite encouraged by our animal data, and in fact, we're going to go do probably an enriched pancreatic cancer trial based on certain findings that we have. But I'm sure Mitesh has seen the same. Is that viruses care a little bit less than molecules trying to get there. Okay, and viruses. Mitesh has already said that this is a nanoparticle. You could think of viruses as nature's self-replicating nanoparticle. That's what it is. And so even though we're not allowed to apply for any of the nano grants, okay, because it specifically excludes viruses, that's what they are. And I think the replication and the ability to infect tumor cells and replicate within it and spread amongst it gives a possibility of getting around the stroma. Mitesh?
Yeah, just to add to what Yuman said there, viruses can also be encoded with factors that can help break down the stroma, or you could combine it with things that have been in use, both available clinically and investigationally, such as hyaluronidase or pegylated hyaluronidase that can break down the stroma so you can get more treatment to the tumors. And the difference between this therapy and other therapies is that it can replicate, as Yuman said. So you need a minimum threshold dose that you need to get an infection of. And then you may be able to get sufficient delivery, even though you only got a few particles to a few tumor cells at the end of the day. So unlike other therapies, you have an advantage with the self-replicating capabilities of the treatment.
Thank you very much. I don't know, Stephanie, if you want to add anything.
Yes, thank you very much to both of the speakers. Really interesting talks. I just have a very brief question regarding the clinical trials that are now ongoing. Is there already a selection of patients, or is it not yet in this phase? Also regarding that you saw differences in different cell lines. Can you maybe talk about this? Or pre-treatment, you mentioned radiotherapy.
So our trial, our mass trial is still going, okay, meaning the intratumoral, intravenous of any cancer. And that's because we are barely at doses that I think we are at doses that are still very, very small. And since production of viruses have also gotten so good, we think we could go many logs higher in terms of virus. And not number one, not see toxicity and can afford it. Okay, and but there is a trial, a phase 2 trial, just cholangiocarcinoma that spun off because when the first two people with a certain cancer go in and the data looks very promising, you have to go with the lead. And again, I wasn't my first guess as to what we would enrich first, but I'm pleasantly surprised because cholangiocarcinoma is something I operate on every week, okay? And so I've been treating clinically patients with cholangiocarcinoma forever. I was just very pessimistic that we would find solutions for it. And if it turns out that we have accidentally found a solution in my own lab, that would be amazing, okay? And so very excited about it. But again, your viruses in Heidelberg have also been quite interesting. So looking forward to everybody's viruses coming forward and making these tumors hot, seeing responses and moving the whole field forward. And I'm just hoping that I will have T cells for everybody to go, okay? Because I'm also convinced that we probably will need to add T cells simply because a lot of the patients that have been on chemotherapy for a long time, I'm not convinced their innate immune system is going to do the final job.
Thank you. I think there's still hope and the future is bright on this. So once again, I would like to hand out the webinar and thank once again Professor Mitesh and Professor Yuman Fong for these brilliant presentations. And of course, acknowledge ICRN, the EMSCA, and the Precision-BTC-Network on the organization of these webinars. I would like to remind you on the next two-part webinar that we are organizing on PSC-related cholangiocarcinoma. And the first part on screening, prevention, and early diagnosis will be held on December 5th at this exactly same times and will be organized in collaboration with PSC partners. In the meanwhile, do you have here a QR code in case if you want to join ICRN, in case you are not still part of. And we would like to ask you to take some 1 or 2 minutes to complete this post-webinar survey in which your feedback will be asked for and will be for sure available for us to improve future sessions. And last but not the least, in case you want a certificate of live attendance for this webinar, please write an email to research@cholangiocarcinoma.org, and a certificate will be provided you. So in the meanwhile, if you can fill in the survey, we will be very thankful.
Thank you, everybody.
Thank you for the
Thank you.
excellent talks. Thank you. Yeah.
Bye.
Very
Thank you
nice
very
meeting
much.
you. Thank you.